My topic for the case study was cerebral palsy, or CP. So some things I want to talk about are the prevalence of CP within the United States, the pathophysiology of CP, some clinical considerations that we as exercise professionals should take into consideration, the exercise response and effects, medications that a lot of individuals with cerebral palsy utilize, and how they're impacted during exercise, and then go into the case study and do the risk stratification, the exercise testing, and the prescription. So to start, on the prevalence in the United States, the graph that you're seeing here is from a study done in 2008 by the CDC, and the CDC had 4 tracking sites throughout the United States, one in Alabama, one in Georgia, one in Missouri, and one in Wisconsin. And they found how many 8-year-olds within that tracking site had CP. And then they averaged them out. So it was about 3.1 in 1,000 8-year-olds had CP. So while this graph doesn't make up a national representative sample, it helped the CDC to estimate that 1 in 323 children in the United States do have CP. So the definition of CP is a non-progressive lesion of the brain occurring before, at, or soon after birth that interferes with the normal brain development. So it's caused by damage to the areas of the brain that control and coordinate muscle tone, reflexes, posture, and movement. And you'll see that individuals with CP typically have deficiencies in one or more of these areas. You can classify CP based on the type of motor abnormality that they have or they exhibit. So spastic CP accounts for 75% of all cases of cerebral palsy, and it's characterized by the muscles have increased stiffness and the movements are very awkward because they have hypertonia or high muscle tone. Athletoid CP is lack of movement control in the hands, arms, feet, and legs, and this is due to the change in muscle tone. So the muscle tone goes from hypo to hypertonia or vice versa, and these changes are daily. They occur throughout the day, or they can occur every other day. It just depends on that specific case. And then you have ataxia, which is characterized by clumsiness and instability, and this is due to the interruption of muscle control in the arms and legs, which then results in balance and coordination control problems. The next way to characterize CP is the location of the lesion on the brain. So the pyramidal lesion is a lesion on the cerebral cortex, and this directly relates to spastic CP. Extrapyramidal is the basal ganglia or the cerebellum, and this is respective to athletoid and ataxia CP. And then you can have a mixed, which is a combination. So the last way to classify CP is at the area of the body that is impacted, and this is typically spastic CP. So the picture on the right is an example of some different forms of CP, and it shows you the yellow half is the half that's impacted. So hemiplegia is one side or one hemisphere of the body is impacted, so one arm, one leg, and one trunk on the same side. Diplegia is where one symmetrical part of the body is impacted, so either both legs or both arms. Tetraplegia is where all 4 limbs are impacted, but 3 are impacted more than the other one. Monoplegia is just one limb that's impacted. Paraplegia is the lower half of the body, so these individuals are typically non-ambulatory or they don't walk. Triplegia is where 3 limbs are impacted, and then quadriplegia is where all 4 limbs are impacted. So some of the risk factors or causes of CP, premature birth and low birth weight have the highest correlation to CP, and this is the most common reason CP does occur, with 35 to 40% of CP cases being relegated to that. Twins and higher order of multiple birth infants, maternal or fetal abnormalities in coagulation or clotting, and the presence of factor V Leiden mutation, maternal fever during labor term, abuse of drugs and cigarettes, congenital brain malformations that impact the places of the brain that we talked about in the previous slides, genetic conditions, and then complications during the birth when it's happening that can cause anoxia or lack of oxygen, or hemorrhaging with direct brain damage. And then postnatally, an individual can still acquire CP due to meningitis, traumatic head injury, vehicular accidents, abuse, really anything that can cause damage to one of the functions of the brain that we talked about, one of those locations. And this picture on the right-hand side just is a breakdown more in depth of what causes that CP has had. So some clinical considerations for neuromuscular, these are primary conditions or primary symptoms, characteristics of CP. Some deficit symptoms. One is paresis, which is the muscles elicit inadequate force. Loss of selective motor control, which is they have trouble isolating movements across one joint or a specific joint. They experience a loss of dexterity in movement, and they have enhanced fatigability. A study conducted by Murphy and colleagues reported that 75% of their cohorts discontinued ambulation or walking by the age of 25 due to enhanced fatigability and then inefficient movement. So this is very important. This is a very big concern to a lot of individuals with CP. So when we make our workout prescriptions, we have to keep this in mind. So some excess symptoms are hypertonia or increased muscle tone, muscle contraction, activation. Spasticity is resistance to passive movement or increased stretch reflex. Clonus is the involuntary rhythmic muscle contraction. Co-contraction is an involuntary muscle contraction at the antagonist muscle when you're voluntarily contracting your agonist muscle. Hyperreflexia, a lot of individuals with CP retain their reflexes from birth. They don't outgrow them. So also the pain reflex increases as they grow older. So a lot of them experience pain at a higher intensity than we do. And then they also exhibit contractures, which is the shortening of a tendon. So a lot of their arms look like, I don't know if you see it, look like that, like they shorten a lot. And this is just some things on the side to keep in mind. They have bowel and bladder issues. They have incontinence. 2/3 of individuals with CP also have an intellectual disability. So if you're working with someone like that, you have to make sure that you break down the steps and really demonstrate each exercise the way you want them to do it. So they can have learning disabilities, ADD, ADHD, and sensory integration disorder. They have some musculoskeletal problems like bone loss, fractures, hip dislocations, and gait abnormalities, which can increase and cause a scissor gait. They may have oral motor dysfunction, such as drooling, poor motor control, or dysphagia, which is difficulty swallowing. And they may have respiratory problems, which include blocked airways, airway inflammation, or diminished ability to clear secretions, which can cause them to choke or cough a lot. Many individuals do have seizures and epilepsy, and they do have CP due to the brain damage. And they can have vision deficits, so strabismus is cross eyes or hemanopia, which is blindness of more than half your field of vision. So how does exercise affect CP? I found 2 studies that focused on strength training and one focused on strength anaerobic training in children with CP. One was a 12-week strength anaerobic interval training program, and the other one was a 6-week home-based strength program. But they both really found that, aerobic one found that it reduced oxygen cost of arm cranking, it improved the aerobic capacity, and it improved gross motor function, while the 6-week just strength-based program found that strength, flexibility, posture, and then the ability to negotiate steps improved, which is important for activities of daily living. They found an increase in psychological well-being, and they improved participation in school and leisure activities. So outside of these studies, I also found that it improves heart rate and blood pressure. The flexibility helps to improve the range of motion and coordination. They have decrease in body fat and BMI, and it also helps them to improve ADLs, which helps them in the long run to maintain a longer independence. So some medications that are important, so I'm going to point some of the ones out that we haven't talked about. So the anticholinergics are for uncontrolled body movements, and this is important because it decreases sweating. So if you're in a hot environment, they could become overheated very fast, so it's important to keep this in mind. Anticonvulsants are seizure medications. and this creates problems with speech, balance, or walking. It could, so you want to watch out for that if you're trying to have them do ambulatory things. Antidepressants, anti-inflammatories elicit high blood pressure, so that's important to keep in mind as they're doing their exercise training and prescription. Stool softeners, they increase sweating, so you want to make sure they're intaking a lot of fluids so they don't become dehydrated. And antispastic is dizziness or blurry vision. So I'll go more into the case study, the risk stratification in the next slide. But this side, the diagnosis is CP. She's a paraplegic. She's non-ambulatory, so she doesn't walk and she utilizes a wheelchair. And she has incontinence. Her medications include anticholinergics and antispastic medication. And her goal is to lose body fat and to gain muscle. So she is 22 years old, and that's not a risk. Her father had a heart attack, but because it's over the age of 55, it's also not a risk. She's a non-smoker, not a risk. She lives a sedentary lifestyle, which is a risk. And her BMI is 33.4, so that's a risk. Her blood pressure is 142/78, but her systolic is higher than 140, so it's a risk. Her LDLs, HDLs, and TCs are not risks. And her triglycerides are over 100, so it is a risk. She is asymptomatic, but she has 4 risk factors, so she's at moderate risk. And you should seek medical clearance before doing any physical fitness, just due to the high number of comorbidities with this disease. So for her testing, flexibility is very important because of the tone of all the muscles and the weaknesses, things like that. So it's important to do the sit and reach test and the athlete scratch test just to gauge her flexibility as it is now. Cardiovascular, because she is wheelchair bound, I did an arm ergometer test instead of a wheelchair push test because it's easier to control the workload. You can set it. So you begin with the starting power of 0 to 15 watts at 30 to 50 RPMs, and then begin to increase 5 to 10 watts every 1 to 2 minutes until fatigue. And you want to keep track of heart rate, blood pressure, VO2, and do an ECG to make sure her heart is working okay. For strength and exercise testing, I'm doing machine instead of free weights because of the tone of the muscles. For CP, it's easier and it's safer to do something that's in a closed chain instead of an open chain. And also, it's easier because if their tone starts to get increased or decreased, then the machine you can let go. The machine's a safer environment than a free weight, especially because she's been sedentary before this. So it's all upper body, core and trunk strengthening, just to see where she's at with that. And it's important to test these groups unilaterally because spasticity isn't the same on each side of your body. And for this, you want to focus on stability, coordination, range of motion, and timing. So for the prescription, for the range of motion for flexibility, you really want to do stretching, PNF, active assistive stretching. You want to stretch the large muscle groups, and especially the ones that have hypertonicity. You really want to make sure that you're taking care of them and really making sure that you're warming them up and cooling them down for aerobic and strengthening exercises. So you want to do that 3 to 5 days a week. And you want to maintain the stretch to the point just before discomfort for 30 to 60 seconds per stretch. Through the ACSM, flexibility is very, very important to do before resistance training and go currently with resistance training to make sure that you're not over fatiguing the muscles as you're working them, and then you're really going back and you're not really improving as much because of how fatigued they are. So for resistance training, I'm prescribing exercise machines, once again, to stay in that closed chain. It's a lot of upper body strengthening and core strengthening and trunk strengthening for posture. And then I also am including knee extension just with body weight and maybe guidance if needed, as well as plantar flexion and dorsiflexion of the ankle. Also just the body weight, no weights, with support if needed. This is 2 days a week. Lower resistance is utilized or to fatigue, and then 3 to sets of 8 reps. So lastly, you're going to do cardiovascular. Non-weight bearing activities include swimming, water aerobics, hand cycling, arm ergometry, and the recumbent stepper. And this is to alleviate pressure on the joints and because she is a paraplegic as well. You want to do this 3 to 5 days a week at a moderate intensity to start at 40 to 50% of heart rate reserve, and then progress to 50 to 80%. And you want to do this 3 for 10-minute sessions. And those are my sources.